برحب بحضراتكم. Actually, in the schedule, it is two parallel sessions, meet the expert. One for the intervention pulmonology, and the other, the pulmonary critical care. And we found that many of our colleagues like to attend both sessions. So, at the end, we'll make it one session. It's my honor and pleasure to moderate this session or co-moderate this session with my colleague and friend, Professor Ala Al-Gindi. We have two panels because we are the Egyptian Scientific Society of Bronchology. The board or the expertise of bronchoscopy are here. Pulmonary ICU or critical pulmonary medicine should be in the stage, but they are here. We will take a question for the intervention pulmonology and then question for the critical pulmonary care. So, without any further delay, we'll start with question for intervention pulmonology. Any question? I need a microphone back. Microphone. Maybe I'll start myself by a question to Professor Semra, our colleague from Turkey. One of the interesting issues now we have in Egypt, I think all over the world, many cases of interstitial lung disease. What to do to take a biopsy from peripheral nodule or peripheral lung disease? Cryobiopsy or conventional transbronchial biopsy? What do you think? The yield, sensitivity, specificity?
In my hospital, in my experience,
I think you take this one.
we don't do cryobiopsy yet. We are doing transbronchial biopsy. Our yield in interstitial lung diseases is about 60%. For nodules, again, it's not above 60%. With the new literature on cryobiopsy for interstitial lung disease and peripheral nodules, showing that the biopsy specimen much larger than transbronchial biopsy, conventional transbronchial biopsy, and the diagnostic yield is higher than the conventional one. I think doing cryobiopsy is much better, but whether it can be done in every hospital, it's debatable. The diagnostic yield is not significantly higher than the conventional transbronchial biopsy. It is higher, but there is no significant increase. And also, they say it's safe to perform cryobiopsy, but there can be significant bleeding due to cryobiopsies. We have to be careful with that. Conventional transbronchial biopsy is not very innocent. It has complications such as pneumothorax, but when we compare the complication rates, according to the literature, they say the complication rate is comparable. I'd like to try cryobiopsy for my own patients for peripheral nodules and interstitial lung diseases, but if you ask my first impressions, I don't think there is great difference between two biopsies. Only the specimen is larger, but we have to see more studies done, larger studies done on this method. I'm kind of hopeful, but I want to see more results.
Thank you, sir.
During the break, we had an interesting discussion with Dr. Nazar and Dr. Islam about the emerging resistance in the ICU, in terms of microbiology. So, Dr. Islam, would you like to elaborate?
Thank you so much. It is obviously an outgoing problem and the progressing problem in ICU for the world. I remember when we first opened our ICU at the IMC, we had published a study, and we were so proud of it, that we had almost zero nosocomial infections, especially VAP in the ICU, and that went on for a full year. And as time went on, the resistant bugs emerged. Part of the culture, probably in the Middle East, and I find that very true in Saudi Arabia. Number one, the system does not allow chronic patients to find a place outside of the ICU. In the States, they tackle this problem by generating step-down units and also generating whole hospitals to care for the chronically ventilated patients. And then they came up with a system called LTAC, long-term acute care hospitals. So those patients who tend to stay for a long time, and those are the ones who are going to be brewing some of those resistant bugs because they will go through several courses of antibiotics. Obviously, the use and the overuse of antibiotics is the main reason why we develop these resistant strains. So in the Middle East, or particularly talking about Egypt and Saudi Arabia, I don't think this system is available, where you take the chronic patients and separate them away from the acutely ill in the ICU. And I think that's probably one of the major reasons. The other thing is also the liberation of antibiotic use in the Middle East and the lack of regulations. Like in the States, you cannot really get an antibiotic at a pharmacy without a prescription. We know that in the Middle East, a lot of people can just walk into the pharmacy and get lots of antibiotics. So there is certainly an abuse pattern, both by patients and by professionals as well. Now, the resistance that we see in the ICUs, especially with ventilators and ventilator-associated pneumonias, a lot of times have to do with the level of care in the ICU. I know the ventilator bundles came up, and then the proper prophylaxis and the proper care of patients, the elevation of the head of the bed, and the decontamination methods, and all these things, they're not always followed literally in all ICUs. So I think this just is a general look as to see why we are facing this problem. Now, the question is what to do about it. Obviously, stewardship. A lot of programs have adopted antibiotic stewardship. For example, where I practice at UCSD, you're not at liberty of prescribing certain antibiotics. You have to have a passcode from the infectious disease consultant on call. And they change the password constantly. So if you, for example, want to use an antifungal, mycofungin, for example, you cannot go ahead. The pharmacy will release the first dose as an emergency basis. And after that, the medicine will be automatically discontinued until you call the infectious disease service and get them to approve it for you. So things like imipenem and meropenem and antifungals and stuff like that, they are all controlled and they are under scrutiny and constant review of people who know the antibiogram of the hospital, the resistance pattern of the hospital, and they are the best to judge you and to guide you. And this is very helpful. It really helps physicians avoid this pattern of abuse in the ICUs. And I think implementing a system like that might be the first step in regulating the use of antibiotics. Thank you.
One of the things that we've done too in the States is to screen everybody coming into the hospital before the admission to identify the community-acquired MRSA. So at least we know these patients from the beginning before they get to the hospital and then the infection gets spread. Thank you.
And we routinely consider every patient who's transferred from a different facility as MRSA positive till proven otherwise.
In cases of lung cancer, we have many cases now. And as Atul Mehta advised, with all respect to Professor Ahmed, thoracic surgeon, Professor Mehta said, keep the surgeons out from foreign body extraction and staging of, he said, not me, Atul Mehta, and staging of lung cancer. So, Professor Rosman from Slovenia, what is the role of intervention pulmonology in staging of lung cancer?
Well, thank you for the question. I think it's a very good one.
Would you? The mic. It's working.
Thank you. I think it's the important question because at least in my hospital, in my ward, we strive to do three. When we have a patient with lung cancer, we need three diagnoses. The first one is the type of the cancer and the mutations and so on. The next is exact staging, and the third one is the performance status of the patient, because we need to know how can be treated if he's able for operation or for chemotherapy or radiation and so on. And the second thing, like staging, is very important. I think that I will show tomorrow in the lecture that non-invasive staging is not accurate enough because the accuracy of such type of staging is around 90% according to CT scan, PET scan, and so on. And we need to go into the bronchi with EBUS-C lymph nodes and puncture them exactly. There are several clinical scenarios according to how big is the tumor. Are there lymph nodes present in N1 stage? Are there in the mediastinum normal sized lymph nodes or enlarged lymph nodes? There are many situations, but I think it's very important. At the moment I think that the invasive staging with EBUS puncturing is pretty much invasive because we need to do systematic sampling of all lymph node stages in N2 and N3 positions, not maybe as we think about this several years ago that we puncture only in large lymph nodes. This means that sometimes we do 20 or even more punctures per patient. So I think that we need to find some additional non-invasive measures to select these lymph nodes better, which are suspicious or not. There are some emerging technologies coming. For example, EBUS elastography is one of them, where we are able to see, of course, this is experimental method so far, where we are able to see if the lymph node is more rigid or more elastic, and according to this, we might in future select certain lymph nodes which need to be punctured or not to be punctured. But at this very moment, when we have certain clinical scenarios, I'll show tomorrow on the slides which clinical scenarios are there. We need to do a systematical sampling of all these lymph nodes on N2 and N3 stations, not just in the upper mediastinum, but also lower at 8 and 9 positions. With EBUS, we can do, with EBUS bronchoscope, we can do both things, stage from the trachea and also from the esophagus, because it's very easy to go in the esophagus with the same instrument during the same session. And now a study is running about left suprarenal gland, and according to preliminary data, we are able to visualize left adrenal gland, left suprarenal gland in about 75-80% of the cases, and the puncture is also possible in around 60 or 70% of the cases with EBUS bronchoscope, the same instrument, the same session.
Thank you so much.
Any questions from the audience about the ICU? Go ahead. Dr. Gamal Rabia.
Professor Islam, we all know that CPAP has an excellent role in the treatment of pulmonary edema and also obstructive sleep apnea. What about pulmonary edema presenting with hypercapnia? Is there any role for CPAP, or the best is to use BiPAP? The second question, what about the use of CPAP in treatment of chronic obstructive lung disease?
Thank you so much. So obviously, non-invasive mechanical ventilation, CPAP and BiPAP, it obviously buys you time, and it has proven to be very helpful in patients with pulmonary edema, congestive heart failure. Increasing the PaO2, the partial pressure of oxygen in the alveoli, is what drives your oxygenation down the gradient into the blood. And anything that would increase that positive pressure is going to help with the oxygenation process. And through the studies, the value of using positive pressure ventilation in patients with pulmonary edema had been proven beyond doubt. And obviously, in COPD as well, it can also buy you time and prevent you from going into intubation, especially when the patient presents with type 2 hypercapnic respiratory failure. Now, whether you compare CPAP and BiPAP, I think for the acute respiratory failure, especially hypercapnia, the use of BiPAP is superior to the use of CPAP. Obviously, someone with sleep apnea who's routinely using CPAP at nighttime at a set rate, especially now with the automated CPAP, titratable to the type of resistance, and I think we can get some more comments also from our colleague who's more practicing into the sleep medicine era. What was the second question? I'm sorry. The use of BiPAP in COPD? Use of CPAP in COPD. I find it a very good method to send patients with terminal or maybe close to terminal COPD, very advanced COPD, who are going home, to be maintained on some sort of CPAP to prevent hypercapnia from bringing patients back into the hospital. So I do use it in my practice for patients who with advanced COPD, obviously FEV1 less than 1.5, who are more prone to developing hypercapnic respiratory failure.
In terms of the, can I add the, is it the same question or it's a different question? Good, okay, I'll just add a couple notes on the use of the CPAP and the BiPAP. In the non-invasive mechanical ventilation, it's the same equipment, but it's a different concept. In sleep medicine, we tend to use this in a chronic stable patient, but in the ICU, it's an acutely ill patient. So number one, we need to have the mask very tight in the ICU. In the non-invasive in sleep, we can allow some air leaks. The other thing is that in the non-invasive, in the ICU patients, we got to find out why did this patient fail. The patient could have failed because they have a high inspiratory demand. They could have failed because of the hypoxemia, or they could have failed because of the hypercapnia. They could have had a respiratory failure secondary to a pneumonia. So a pneumonia on top of a COPD, using the non-invasive might not be a good choice at the beginning, especially if the patient has secretions. It doesn't mean not to try it, but sometimes we tend to try it and we hope for the best and we wait for 48 hours and the patient doesn't get better, and then we end up with a code situation where we put an ET tube. So it's always the first intervention in the first 15 minutes to half an hour is what counts. So if you feel that you're going to use the non-invasive and you're going to get the patient by, then fine, use it. But if you're hesitant, then you got to go for the intubation and not be afraid. The earlier intubation could mean earlier extubation in the right conditions.
Professor Mack.
Yeah, going back to the infectious issue in the intensive care, I've no doubt that making international guidelines available and sticking to it with early onset and late onset infection modes of treatment is very good. Also cycling antibiotics is very good, and having an infectious control committee and giving it authority over intensive care units is very important. But still, I would like to emphasize the importance of two major points, which are very simple. Hand washing, number one, and number two is elimination of any staff who is sneezing, who is coughing and working in the intensive care. We go in the intensive care and see the nurse who is coughing and is taking an injection for her fever, and she is caring for a patient who is under mechanical ventilation. So hand washing and the care provider's mode of transmission of infection to the patients should be taken care of. Thank you.
This is very important. Also another important issue to decrease, not to prevent completely the infection in the hospital and mainly in the ICU, surveillance of the organism and resistance, and then cycling of the antibiotics according to the results of surveillance, closed formularies of one or more or two antibiotics from each class for each bug. This all is very important issues. Professor Safwat, we have many modalities now, and there is progression and update in intervention pulmonology. But I think the most important is the safety of the patient with all these modalities. What about the safety criteria and precautions in bronchoscopy or intervention pulmonology in general?
Thank you for the question. Number one, you should be well oriented about the procedure, and you have to have a good experience about it. That's very important. You have to get some, training about it. So if we're talking about bronchoscopy, we should go into the basics first. Before going into bronchoscopy, you have to have a proper history of the patient. I mean, blood pressure, ABC, that's the proper history of if he's diabetic. Don't go into patient who is not uncontrolled. If he's having pulmonary hypertension, take care. You have to have a workup of very basic things, platelets. If they are less than 50,000, avoid biopsies. And it should be more than 75,000. So you have some basics. If a patient is a COPDer, are you going to perform a bronchoscopy for a patient having a high CO2 and giving him a high flow oxygen? So you should control the oxygen therapy for those patients having COPD. If a patient is an asthmatic and he's uncontrolled, you have to control it with the bronchodilation before going in. So these are very basics. If he's having ischemic heart disease and he got an acute MI, postpone the procedure, but after 6 weeks you can go on if his condition is stable. Another point which is very important, we're pushing too much xylocaine or lignocaine sometimes, so we could develop lignocaine toxicity. So preferably you give it 4 milligram per kilogram body weight or maximum 300 milligram. If the patient has having renal problem, hepatic problem, and you're giving him too much lignocaine, he can develop toxicity. The other point which is very important, we have a lot of patients on anticoagulation, like for instance Plavix. We should stop the Plavix 5 days before. Aspirin, I believe we can proceed with an aspirin, but if he's on warfarin, this is very important. His INR should be less than 1.3, or you switch to heparin, and having the backup of vitamin K or plasma, etc., if he develops any problem of bleeding. So we have, some points which should be, we should inform the bronchoscopist before going into the procedure that he should put it in mind. For rigid bronchoscopy, the person which is part of our intervention, he should be well trained, because we can get a lot of catastrophe doing the procedure. And we should have as well, one of the precautions, if you're doing the bronchoscopy, the endoscopy suite, you have to have the whole backup, like oxygen. If you develop bleeding, you can have a backup of transfusion, etc. So I believe these are very important.
Can I add a point?
Please.
As regarding the interventional bronchoscopy, it's a no harm procedure because it's a palliation. So some of the interventional bronchoscopists want to reconstruct the airway, but the patient have many debilitating condition and his life expectancy is too short. So it's important to select the cases, not to be eager to do reconstruction for nothing. The lung is collapsed and you have no airway distally and things like that. So most important, that's no harm. The patient will benefit from the procedure because most of our procedures are of palliative intent. So do not push too much. This is when the interventional pulmonologist is skilled. Sometimes he do unnecessary for the sake of reconstructing of the airway only, and the patient, after we follow the patient, we see that the patient does not benefit from this procedure. So the most important that our concept is palliation and no harm to the patient. This is the point that I want to emphasize.
Thank you, Professor Madkour.
Ahmed Al-Busefi from Libya. Regarding interventional bronchoscopy, and we know about bronchial thermoplasty from the expert people in the whole, we need the pre and post thermoplasty regarding the experience. We know that certain centers working on the bronchial thermoplasty in the world nowadays. We need to emphasize or to make a flash regarding what's the outcome before and after severe bronchial asthma using bronchial thermoplasty.
As I have mentioned in the Memorial Clinic this afternoon, bronchial thermoplasty for bronchial asthma emerged in 2006, literature starting from Cox. Would you like to comment on the inquiry, Sandra? Yep.
Thermoplasty, if we choose asthma patients it works. But we have to choose the right patients. Not every asthma patient is an indication for thermoplasty. And when you count the number, these patients are not big in number. So there are some studies done. Some of them are very well studies. I believe that thermoplasty works and the outcome is good. There are not big complications and the procedure is simple if we choose the right patients. They should be not very, moderate patients. These patients should have had enough drug treatment, inhaled treatment. Everything should be done, and there is no, improvement with these drugs. And then we can choose thermoplasty as a relief procedure. Otherwise, we cannot apply this procedure to every asthma patient. As my colleague said, we shouldn't be pushy in interventional pulmonology. We should choose the right indications for any interventional pulmonary procedure. Plus, maybe that patient does not have need for thermoplasty. If it's the right patient, it works. Because there is no other cure or improvement for the patient, you have to choose that treatment. And the person who is doing should be an experienced person who knows everything well. This is true for every interventional procedure. Nowadays in my country, everyone wants to do interventional pulmonary procedures, but do they have the basic knowledge? Do they have the experience? And they want to climb the mountain to the top of the mountain without getting the basic bronchoscopy education or training. From my viewpoint, we learn everything from the first step. We have to take steps one by one. First, we have to know how to hold the bronchoscope, how to maneuver the bronchoscope, learn the basic bronchoscopy, and then put on top of that thermoplasty and other procedures. That's what is going on in my country. Everyone is so enthusiastic, but too much enthusiasm and too much impatience can cause catastrophes.
Professor Rosman?
I may say also a few words about that. As Simra said, the selection of patients is very important here. So far, we have only one really serious study of larger number of patients, and this is AIR2 study. And if you see inclusion criteria to that study, these are the patients whose asthma is not too severe. So they have uncontrolled asthma, but not catastrophic asthma. These patients weren't intubated or didn't have very serious worsening in the past year before they were enrolled into the study. I personally think that people with so-called old asthma with bad reversibility of lung function testing are not appropriate candidates for this type of the procedure. So we look for younger patients with good reversibility and not catastrophic history of catastrophic events in the past. At least in my experience is that the procedure is pretty safe, and the only question is, will it work in the patients or not? Because so far we didn't notice any serious side effects, and even in the studies were not published so far. But the selection is very important, yes.
Professor
What about the long-term effect? We didn't have any long-term effect of this procedure. It's a short-term. Most of the study, AIR1 and AIR2, we didn't see after 10 years of doing these procedures. What about the recurrence? What about the patient, his condition still stable or not? What's your impression?
The follow-up of AIR2 study, there was one publication 5 years after the initial treatment of a patient in the AIR2 study. They performed high-resolution CT scan, and there were no sequelae of this procedure like bronchiectasis and so on. So the patient seems to work fine, to do fine after 5 years, and they have a lower level of worsening of the asthma. It seems that their asthma is still there, but it's not so bad anymore.
Comment from Professor Islam.
Yeah. I think when the thermoplasty first came out, it was like a miracle or a silver bullet that came out to solve severe asthma, hard to control asthma. And then it kind of like fallen down as maybe a 50-50 chance. And I think maybe as more of the inexperienced physicians got into the field and everybody started doing thermoplasty without the proper selection, then you started seeing less effective results. So that also agrees with what you just said. But let me ask you something. I mean, we know how thermoplasty works by reducing the muscle mass in the muscularis. Do you recommend getting a muscle biopsy, I mean an airway biopsy, to measure the thickness of the muscle mass before you select your patients for thermoplasty?
I'm not pretty sure on this that every patient needs a biopsy before starting the treatment. At the moment, we don't know exactly how the method works. We see that, at least in animal studies, there is some reduction of smooth muscle cells and less exacerbations and so on. We should perhaps thinking about maybe the most vulnerable structure in the bronchial wall who may respond to this treatment are basically vagus nerves. And maybe this is a consequence of partial denervation of vagus. So if smooth muscle is denervated, then the atrophy comes, and also there is less secretion and less vasomotoric stimuli as well. Maybe this is the mechanism how bronchial thermoplasty works.
So I would like to take about, I don't want to make a presentation of thermoplasty, but I can't hear thermoplasty without commenting on it. Number one is the selection. I've introduced the thermoplasty in the Southwest Florida, and it happened that most of my patient population are Spanish population. Asthma is more prevalent among the Spanish population. The initial studies did not include the Spanish population or looked at what happened to the response. The number of patients that I had was limited, but all had a favorable results, and they all followed the results that we had from the year 2. There's definitely more than 80% improvement in their ER visits and their doctor's visits. I could not get any of them not to use their inhalers, but definitely all got a better quality of life. They all got less exacerbations. They were not as frequent flyers to the hospital as they used to be. Actually, I did a modified part of the technique by introducing the catheter through the curette, the sheath from the Olympus. And I was able to treat more airways than what the company recommends. The company recommends about 25 to 40 activations, but there are times that you need to treat more airways. It's an individual cases. It's like the LASIK. The patient had one shot added at each lobe, so this procedure is not going to be done again. Having this procedure in the untrained hand or improperly trained hand, again, might cause more harm. Go ahead.
From your experience, what about the middle lobe? Are you
the middle lobe, you're not going to find anybody going to treat the middle lobe because of the Lady-Whittemere syndrome. And the company was very smart. They did not include that as part of the treatment. And their excuse was that the segment is short and it's narrower. But they stayed away from it, so they don't bias the results. So nobody's going to treat, in the US at least, because it's not FDA approved to treat the right middle lobe. And it's done on 3 sessions. It's a little bit on the expensive side. Last year, when I presented my presentation, I made a comment and I got attacked from one of the audience, but I did not mean it that way. When I said that we're a pulmonologist, it's about time that we think like a cardiologist. What I meant, not putting stents in everybody. What I meant is risk stratification. With risk stratification, we always look for medication, we look for ways to prevent, and then finally, we'll look for a procedure when we do number 1 and number 2. So with the risk stratification of the asthmatic patients, first we got to find out what triggers the attack. Number 2, maximize the therapy. The number 3, that's when I will resort to the procedure, and the procedure works. But after 1 and 2, not to jump into the procedure immediately. The one note here is that I did not do this procedure on any of my patients aiming to get them off steroids. After post-market studies, there were some recommendations from the company and from the representatives of the company that was not validated, that you can use this procedure to take patients off prednisone. These patients were excluded from the initial studies. So really, we did not have data on those patients. That's my comment on thermoplasty. Now, the next question on the ICU. Go ahead, sir.
I have inquiry to Dr. Islam. From our recent practice at Qasr Al Aini Faculty of Medicine, we notice in the ICU we have high incidence of VAB, MDR Pseudomonas, and MDR Acinetobacter, and even NDM strains. We have high incidence compared to that before. Most of those patients, we found them have impaired kidney function. And the only available treatment for those patients was cholesterol. Unfortunately, we cannot give cholesterol to this impaired kidney function. We try to find a way to give the cholesterol. So we try to give it by inhalation. Our preliminary results encouraging, but still in the beginning, trying to give the cholesterol by inhalation to avoid nephrotoxicity, because we know cholesterol is highly nephrotoxic, and those patients already have impaired kidney function. So I need to know from Dr. Islam if any input in this area. What shall we do? We tried, by the way, we tried to give several combinations. Majority failed. So if Dr. Islam can add to this point. Thank you.
I think we have a similar problem in our hospital in Saudi Arabia, actually. Like I did mention, many of the patients stay in the hospital for too long, particularly in ICU, and they're on the ventilator. And then initially they start with the sensitive Pseudomonas and sensitive Acinetobacter, and with time they build resistance. And we do have quite a few patients with MDR, Pseudomonas, and Acinetobacter. We do the same thing. We also resort to nebulized colistin, and so far we have had good results with that. A lot of times also inhaled tubramycin is an alternative if the patient has not tried aminoglycosides. And I think most of the ICUs kind of shy away from the use of aminoglycosides from the start. So I think that group of medications is preserved till the end. So a lot of times inhaled tubramycin or even amikacin, the use of inhaled colistin is your way out. Some of the patients we actually make a decision to dialyze them because the GFR is so low and they are so close to renal failure anyway. And if I think the infection is going to kill them, then saving the life becomes more important than saving the kidneys at that particular point. So we decide to put them on dialysis and use colistin intravenously.
Have you tried the colistin by inhalation?
Yes.
Is this VAB?
Yes.
And what's your results?
We have had good results with it. We had clearance of the MDRs in several patients.
I think in the issue of the multi-drug resistant Pseudomonas, we have to give combination therapy, no monotherapy. Combination is an art. You have to choose antibiotic from first group, which antibiotics, the mechanism of action is on the cell wall, like carbapenems, like third or fourth generation cephalosporin, or anti-Pseudomonas penicillin. With anti-Pseudomonas penicillin, no problem. And as Professor Islam mentioned, I think renal impairment is not barrier because the patient will be already on dialysis. You can give him whatever you want. The second group is antibiotics working on inhibition of the protein synthesis, like the quinolones, Cipro in this case, or aminoglycosides. Now back in the intervention bronchoscopy, Professor Yasser, we talk much about laser, about ABC, cryotherapy, stent. Please remind us about the forgotten brachytherapy, which was your MD thesis. We don't speak much now about or talk much about the brachytherapy.
Yes,
thank you very much, Professor Khattab. Definite brachytherapy is one of the forgotten procedures in our field, although it has a very great value. It doesn't work alone, it works with other techniques. Brachytherapy means endobronchial irradiation or nearby irradiation, by which we put a source for irradiation inside the airway to irradiate the malignancy. Definitely, in the start, it was one type of palliative treatment for endobronchial recurrence. In such patients, we could not give them more chemotherapy dose or radiotherapy dose, external beam irradiation. In the start, there was a high dose rate after loading technique. The high dose rate after loading technique allow us to use the procedure in a very safe way instead of the oldest low dose rate technique. We use a digitally machine, gamma med machine, in which the source it used the dose inside the airways through catheter we inserted through the bronchoscope. Definitely, it is a complementary to other methods. It helped to decrease the rate of recurrence after laser and endobronchial hot therapy by electrocautery, for example. We noticed that such patients develop recurrence rate very rapidly. So if we add brachytherapy to laser phototherapy in EDIAC, for example, the rate of recurrence is delayed. Also, after cryotherapy, they found that from the biological point of view, the cells at that stage after cryo session are biologically active and are very vulnerable to the radiotherapy. So if we add brachytherapy after cryotherapy, it adds a very great benefit for such patients. In very few literature, they try to add brachytherapy from the start in patients with curative intent. In the rationale of that, when we control the primary in a proper way, we decrease the incidence of recurrence and we can decrease the dose of external PE irradiation. Actually, brachytherapy in practice has a very, very limited side effects when used. No serious side effects at all, and it helps a lot in controlling the tumor.
Thank you.
Thank you.
So, any more questions from the audience? Okay, so
Extending the local therapy from the brachy, and the question is open for all the interventionists. Is anyone still using local chemotherapy being injected in the tumors? Do you have any comments on that?
We already have MD thesis was done in Shams about endobronchial injection of chemotherapy. This is have good results and we have good successful rate. But it's important, this is endobronchial chemotherapy is very important in submucosal tumors, in extraluminal tumors. If you have tumor inside the airway, it's easy to hit it with laser, electrocautery, cryo. But the problem in extraluminal tumor, you only can put a stent and the tumor is still growing. So if you combine this with endobronchial injection of chemotherapy, this will be of great value, especially in combined intrinsic and extrinsic tumors. You can hit the intrinsic part with laser or electrocautery and the extraluminal part by injection of chemotherapy. And as Professor Yasser said, it's important also if you use cryo in conjunction with endobronchial chemotherapy, this will augment the effect of the endobronchial chemotherapeutic. So it's beneficial, but there is limited studies. There is Turkish studies. I think one of the leaders is a Turkish study, and it was in our references. But there is no progress in it after that. What? We inject
Professor Samra.
There are different methods of injection. I think we injected cisplatinum, cisplatinum. But the Turkish one, there are many Turkish 5-fluorouracil. They injected many things, but we use cisplatinum. Some of us, it's important that you choose patients of, for sure, non-small cell lung cancer, not small cell lung cancer.
I want to add something. My Turkish colleagues used transbronchial aspiration needle to inject the cisplatin or other chemotherapy. My concern is if the tumor is very necrotic, we are injecting these drugs. Are there any complications?
No, we didn't. We didn't met in our series. It was about 30 cases. We didn't met any systemic absorption of these drugs because we injected the concentration that we injected, and we injected under vision. The bad thing in this endobronchial injection that you should repeat it every 2 weeks for 6 sessions. So it's very bad for the patient to do at least 4 bronchoscopies or 6 bronchoscopies. So it's a very lengthy procedure. But in the second session, we see that the necrotic tissue is sloughed. If there is intrinsic and extrinsic, it's sloughed, and we didn't meet any systemic effects.
By necrosis, I meant since the bronchial wall is involved, too much necrosis in the tumor, and we are injecting the drug. Is there any perforation, fistula, or anything occurring?
No, there was no. Especially in this, you injected in submucosal tumors. You see the submucosal tumor in the CT, and the bronchially show compression from without, and you have large tumor from outside, and you don't have nothing except to put a stent and leave the tumor. So you could select good patients, not those with the small tumor, extraluminal extent. Large tumors with extra tumor.
It takes time.
It takes time. It's a lengthy procedure. So to shorten, this was my recommendation, to shorten this procedure, you should choose it as a combination, not as a single procedure. Combination with extrinsic and extrinsic at the end of the intervention with laser or electric cautery. If you have a submucosal part, do not leave it and tell the patient go to complete the multimodality therapy with systemic chemotherapy. You can inject as well endobronchial chemotherapy, and also you can use cryo in the same session at the end of the procedure to augment what you have injected. So my concept that it is very important to add as an add-on at the end of the procedure of the interventional procedure. This will be the main value, not to do it we did it as a only procedure. But if you do it in conjunction with other methods of interventional bronchoscopy, will be the added value.
And also the effect will be more, the complication rate will be less.
For sure, for sure. No, up to my knowledge, nobody injected the lymph nodes, because if you know the lymph nodes, you cannot inject all of the lymph nodes.
Omar Al-Gaili, Dr. Omar Al-Gaili from Sudan.
Thank you very much for this opportunity. I think the prevalence of tuberculosis in our country is very high. In Turkey, in Egypt, in Slovenia, in Sudan, also the HIV and BCV. What is the role of intervention bronchoscopy in diagnosis of tuberculosis and BCV? Thank you.
Should I answer? There may be different ways of treating tuberculosis interventionally. One that is coming to my mind is tracheal stenosis or bronchial stenosis. Nowadays we don't see it too much, but there are still some patients with stenosis in trachea or bronchi. Interventional pulmonology can be helpful in that, depending what type of stenosis it is. Sometimes it's just web-like stenosis. It's simple stenosis. It can be managed by endobronchial treatments with laser or argon. But if the bronchial wall is involved, of course surgery should be involved in it. Maybe we should consider with surgeons. If no surgery is considered, then maybe stenting or maybe dilatation first, and then stenting can be used. Another issue in tuberculosis is, again, we can have tuberculous lymph nodes in HIV positive patients. In adults, we don't see tuberculous lymphadenitis so frequently, but if there is immunocompression, we can see. We can use transbronchial needle aspiration or EBUS-TBNA to diagnose these patients, and we should send the specimen to pathology and also to microbiology to get best results. We can have endobronchial tuberculosis. This is also not very frequent nowadays, but in some patients we still see them. Maybe once a year we see endobronchial tuberculosis. After diagnosing them, of course we should give anti-TB treatment, but sometimes there is a mass in the bronchial wall, lumen. You have to get rid of the mass. Maybe some interventional treatments can be used, not very frequently, to get rid of the obstruction, because sometimes they occlude the main bronchus. I saw one patient with endobronchial tuberculosis, like a mass. I thought it is a lung cancer, but it turned out to be endobronchial tuberculosis. If it is affecting the patient's pulmonary functions, like dyspnea, if there is a symptom coming out of that, interventional pulmonology can be used. What else?
Professor Matkour,
Yeah.
any comments?
We have, at this point, we have last month registered in our university for an MD thesis in one of the chest clinics that deals with TB. The most important is the sequelae of the pulmonary tuberculosis on the airways. As you see, when you see the old tuberculosis patient, you see the patient has fibrothorax, collapsed lung. So if you follow the patients from the beginning of pulmonary tuberculosis or endobronchial tuberculosis involving the airway, you will see the fibrosis in the beginning and before it went to airway collapse. So I have searched in the literature. There are many Chinese studies regarding the management of sequelae of interventional bronchoscopy for the sequelae of the bronchial tuberculosis. So the most important thing that it has no recurrence when you make dilatation, not like in post-intubation tracheal stenosis, it does not recur once more. So when you have one procedure, the patient will benefit from it. Also, you can open collapsed lung, and also you can do what was called collapse therapy, which was in the old days. If you have a cavity, tuberculous cavity, that is not responding to the medical treatment, and the patient is not a surgical candidate, you can close this segment, or with anything like endoscopic reduction, lung reduction surgery, you can stop this. So you have many things to do. This is a point of research that we are starting. Last month we only registered, starting to collect the literature, and we'll tell you the results maybe after 2 years.
And I'll add the stent, if it should be used, the stent should be silicone stent, because for all benign tracheal or bronchial stenosis, metallic stents should not be used, because you cannot get them out later, since these patients have long survivals. Metallic stents are for malignant patients, and silicone stents are for benign stenosis. We should not forget that.
And what is good about this, if you put to the patient post-tuberculous tracheal or bronchial stenosis, if you put the stent for 6 months and you remove, it does not collapse. In most of the series, the collapse is rare. So the patient will benefit, and the airway does not collapse, and you cannot find the fibrothorax and the bad things that you see in the chest X-ray of our old tuberculosis patient. This will benefit from it. At this point, I'm doing this research with Professor Ahmed Qurra, MD thesis in one of our hospital that concerned with tuberculosis.
Professor Matkour, every day when I go to our bronchoscopy unit in Ain Shams University, I find the number of the children, the pediatric age group, is now more than the adults. I think that I got the wrong hospital, children's hospital.
Yes.
The reason is obvious, that they come for foreign body extraction. The question, rigid or fiber optic in pediatric age group?
Yes, the problem of the foreign body inhalation in children, it's more nowadays in our country because of the negligence of it's worldwide, but there is some negligence I see from the patient. The old choice of rigid bronchoscopy or fiber optic bronchoscopy. For sure, the mainstay of treatment of foreign body for many years was the rigid bronchoscopy, because it has an open channel, well ventilation, and there are many ancillary equipments that you can remove the airways. There are some pediatric patients, for sure, from the start I go to rigid bronchoscopy. If I have an emergency, asphyxiating child with a foreign body, it's no time to do flexible bronchoscopy. You should go directly to rigid bronchoscopy. If you have a sharp object which may injure the airway, there is no role of fiber optic in this. If you have very large object, there is no role of fiber optic bronchoscopy in this. If you need to, in very younger children, it is very difficult to do it with the fiber optic bronchoscopy. Otherwise, you can do the flexible bronchoscopy. The advantage of flexible bronchoscopy in the pediatrics foreign body removal, it is less expensive, less injurious. You can do it in the peripherally located foreign bodies, special type of foreign bodies like fluid foreign bodies, or endogenous foreign bodies like mucus plug or blood clot. Also, you can do it if there is powder foreign bodies. Also, you can do it inside the foreign bodies in ICU. And as in American Thoracic Society recommendation, when you have equivocal that you are not sure from the history that the patient has or does not have foreign body inhalation, there is no witnessed foreign body inhalation, you should start first with the flexible bronchoscopy. When we started this service in Shams in 2007 with my colleague Professor Ahmed Qurra'a, we did what Professor Khalid have presented today in the morning. We did 120 patients of foreign body retrieval with the rigid. Only 20% was with flexible bronchoscopy. Then I did the other study that I presented the last ERS with pediatric foreign body with the flexible bronchoscopy. After I gained confidence with the rigid, I started to increase the flexible bronchoscopy in pediatric using the laryngeal mask. The laryngeal mask will offer to you a large size of bronchoscope than the pediatric bronchoscope with the large ancillary foreign body retrieval. And we have good success rate reaching to 83%. And we converted only 6 patients from flexible to rigid, and 1 patient we failed to remove with rigid and flexible. The message that I say, anybody who wants to do flexible bronchoscopy, pediatric foreign body removal, should have good skill at any time to convert the flexible procedure to rigid procedure. You should have the skill to use the rigid and have the option to do, if you have the option to do flexible, okay. But at any time, you should be prepared that you will shift from flexible to rigid. Thank you.
Any questions from the audience? So couple topics that come to mind, and one of them is sleep in the ICU. As a sleep physician, what can we do to prevent the sleep disturbance in the intensive care unit patients in terms of environmental control? And the debate is always going to be, would you cover their eyes or close your ears or cover their ears? Which one will be more effective? Anybody in the audience want to answer?
I think eyes.
So putting earplugs will be more effective than covering the eyes. Even the eyes are the zeitgebers or the gatekeepers for the stimuli, but controlling the noise from the ear is more important than controlling the light from the eye. The other topic is during rounds, we look at the x-rays every day, but we don't pay attention to the chin position. So anybody want to comment, or you want me to answer that too? Is the ET tube movement in terms of x-ray films in the ICU? Okay, so usually my rule of thumb is follow the nose. My anesthesiologists always say follow the chin, the nose or the chin. So if the chin or the nose is down, the ET tube is going to go down. If the nose and chin is up, the ET tube is going to move up. So it's always important to look at the chin on the film before you make the interpretation if the ET tube above the corona or not. I mean, it could be a good position, but this position could change as the time happens when you round in the ICU, and the tube could be pushed forward. On the right side, the ET tube is pushed up, so it pushed outward. On the left side is debatable. It goes either way. Other thing that I can talk about too is the swallow evaluation in the patients. We all know that especially with the elderly, as we're seeing more elderly patients. You want to comment?
Because it's so tricky sometimes on the x-rays, I always go back and check at the how many centimeters at the teeth line. So if it has not changed, I am less concerned.
Yeah, it's more factors. What side is taped? Is it taped at 20 centimeters? And on the x-ray, is it moving up or moving down? Always look at the chin to know if it's going to move up or down. And always the ET tube. That's what we document. We document the size, the placement on the right or the left, so we can make sure that the ET tube is rotated so we don't get a pressure necrosis on one of the angles of the mouth. The other question I was alluding to with the swallow evaluation, especially with the elderly who are coming in with a stroke, what would you do? Most of the people do the MBS or the modified barium swallow. What I developed with the speech pathologist in my hospital is a team. Both of us evaluate the patient. I hold a bronchoscopy for her, and she comes and she starts feeding the patient in a systemic way with the liquids, with the solids, and the gel. and see how the patient is aspirating, and if sometimes we hold the feedings or we advance the feeding accordingly. So this is something that could be picked up by the pulmonologist at the bedside in the ICU to prevent aspirations.
Dr. Gamal. Microphone.
One of the important issues in ICU, especially in the last years, is the use of ultrasound. Ultrasound can be used to detect the endotracheal tube position inside the trachea, and we are conducting this as a thesis in Asyut University. Also, it can be used to detect the to apply the blue protocol, and also the blue protocol, that means bedside lung ultrasound and diagnosis of emergencies, in the diagnosis of dyspnea, either in the emergency department or acute respiratory failure in ICU. And those, you can simply detect the cause of acute respiratory failure just by ultrasound examination, just in 5 to 7 minutes. Also, it is used also in the shock, in the type of the shock and the correction of the shock. And there is also a false protocol, that means fluid administration limitation by lung ultrasound. The message is lung ultrasound is playing now an important role in the management of critically ill patients, especially in cases of shock. You can detect by the ultrasound either this patient is volume depleted or volume overloaded by a simple use of ultrasound just in 3 to 4 minutes.
That's absolutely true. And I can add to that that I routinely now, after I do my bronchoscopy and my biopsies, I do the chest ultrasound looking for pneumothorax. I found it hard for me to learn every aspect of the ultrasound, so I limited my knowledge on that area to only looking for pneumothorax or doing my thoracentesis. Evaluating the heart passes my brain. It's too much for me. But absolutely, yes.
Point related to the use of ultrasound in ICU. There is some debate now about the value of using CVP, central venous line, because the point of having skin necrosis if we inject vasopressors from peripheral seems to diminish, and many studies reveal that it doesn't occur in a great deal of patients. I want to know about this debate, the value of using central venous line, why it is now debatable, and some say it is not a must to do that.
As far as I know, I use a central line. I would not push a pressor in a high dose from a peripheral line. This debate could be recent, but I'm not aware of it.
Yeah, I've seen different practices, and some of the studies, there was a good number of patients who received peripheral vasoactive medications without sequelae. But that's, in the paper that was published, the protocol that was used, there was a check every 2 hours by the ICU attending to make sure there was no extravasation, that the line was in place. So there was constant monitoring of those lines. The minority of patients who did get extravasation did have severe complications. So it was not exactly safe. But I am seeing now in our emergency department in the University of California, when the patient has poor access or when the patient comes in with shock and they didn't have time to put in a central line, they use peripheral vasoactive medications. Obviously, a safe one will be dopamine because it does not cause many sequelae. But I have seen norepinephrine used peripherally, temporarily, until you raise the blood pressure to a certain comfortable level, and then you put in the central line. I'm not comfortable using that therapy indefinitely, but certainly to save someone who's crashing, I would use it peripherally until I get a central line put in.
And I totally agree with you. In an emergency situation, it's a different story. You need to stabilize that patient. But as a routine use in the ICU, I'll always use the central line. I'm not going to use the peripheral line personally.
But like I said in that paper, they were advocating the safety of using vasopressors peripherally. But again, if you look at the study and the amount of tension and scrutiny that was provided to those patients, it cannot be mimicked in other centers.
Question here, microphone here, please.
هلا عبد الحميد من المنيا. سؤالي هنا about arterial line as the invasive method for measuring blood pressure in shock state. Arterial lines, arterial canalization as a measuring method for invasive blood
any line that we're going to do is going to carry a risk of sepsis with it.
Yes.
So unless you're going to absolutely get information that will change your management, I wouldn't rush into putting another line that could be another source of infection.
Dr. Islam?
There is pros and cons to everything. And I think what I would ask myself is, what are the benefits? What do I need it for? How long do I need it for? A lot of times you have a patient who has a very dynamic situation in terms of respiratory failure, CO2 rising, oxygen dropping. Sometimes you don't have a good pulse oximeter reading because the patient is so cold and not perfusing. And you wonder what your saturation is. And you're going to do like frequent blood gases. In that particular case, I think an A-line is justified. I would not leave it indefinitely. As soon as the hemodynamics have stabilized and I have a reliable peripheral cuff reading for the blood pressure and no strenuous need to do more blood gases, that will be the time to discontinue the A-line. So usually 24 hours, 48 hours, and I will take it out. But I certainly think it's become a standard use of A-lines for hemodynamic monitoring in septic patients and in shocked patients in the ICU.
Yeah, I agree with you, but at the same time, the most important thing is the reliable. When I was doing my training, we were heavy in Swan-Ganz catheter. Where are the Swan-Ganz catheter now? They kind of died. Nobody put them in unless they're coming from the OR with a cardiac patient, and then we pull them out immediately. So when you ask that question a couple years from now, the answer is definitely going to be no. When I did my training back in the 80s, every patient that was septic, we measured the mixed venous, we put the A-line, every line that you can imagine, we put it in. But now everybody's kind of shying away, trying to find different practices.
My question back to local surveillance programs in antibiotics and antibiogram. How frequent do you advise running these programs in a local hospital or a local area?
Every 6 months. Dr. Gamal.
Regarding the shock, it is the best to use non-invasive techniques to assess the shock, and I again raise the role of ultrasound and echo in ICU. There is a protocol that called a rush rapid diagnosis of shock by ultrasound. You can just you place the probe of sonar. You can detect that it is the type of shock is secondary to cardiac tamponade, secondary to pneumothorax, secondary that can be corrected either by intercostal tube or pericardial tapping. You can say that it is cardiogenic shock by the B profile of, and so there is just 7 to 10 minutes. You can detect the cause of the shock by simply use of either transthoracic ultrasound or echocardiogram.
Last comment.
I think I will agree with every word said here. I'm not going to disagree with it, but at the same time, I think it all stems to the personnel, how trained they are, and the tools that's available. So whatever is available in your hospital, if it's the ultrasound, it's a bedside, and you can use it quickly and you know how to use it, go and use it. If it's not available, and the only thing that's available for you, the A-line, then go ahead and use the A-line. It's the tools and the training that the physician has.
At the end, thank you so much for being with us. I'd like to thank our expertise. I would like to thank our colleagues for the interactive discussion. If you promise me to come tomorrow morning 9, I will tell you where is the dinner. The dinner is offered in a restaurant called, I can't remember. It is my kind of place or my kind of place or my place of kind, something like that. Go to G, ground level, and then go to the old hotel, left side of the lobby, before the elevators, maybe you will find it. Thank you so much.
Let's become my place. This is the place where we have breakfast. So